Welcome to our video on abdominal compartment syndrome. Let's get started. Here's our overview slide. Let's begin by discussing the definition. Compartment syndrome is when the pressure of one or more anatomic compartments increases to the point where tissue perfusion is either decreased significantly or stopped altogether. This would result in end organ dysfunction if no interventions are made. We'll discuss this in regards to the abdomen. We've gone over the pathophysiology of how compartment syndrome occurs in the musculoskeletal lecture, so for this one, we'll discuss how the increase in abdominal compartment pressures result in organ failure. The increase in abdominal pressure leads to compression of the inferior vena cava and portal vein. This leads to increased central venous pressure and systemic vascular resistance, which causes decreased cardiac output and hypotension. There are also decreased thoracic volumes and elevated peak pressures for the lungs as the diaphragm is compressed, resulting in hypercarbia. Compression of the renal artery leads to decreased GFR and low urine output. We'll discuss what can trigger this cycle in the risk factors section. So here's a summary of the previous slide. The increase in abdominal compartment pressures results in organ failure through the following mechanisms. As we mentioned on the previous slide, the increase in abdominal pressure leads to compression of the inferior vena cava and portal vein. This leads to increased central venous pressure and systemic vascular resistance, which causes decreased cardiac output and hypotension. Increased central venous pressure leads to increased intracranial pressure, causing neurologic symptoms. There are also decreased thoracic volumes and elevated peak pressures for the lungs as the diaphragm is compressed, resulting in hypercarbia. Compression of the renal artery leads to decreased GFR and low urine output. The risk factors for abdominal compartment syndrome are directly related to what can cause increased capillary leaking into the soft tissue compartments. This would include patients with multiple traumatic injuries who undergo large volume resuscitation. At especially high risk are those with intra-abdominal and retroperitoneal injuries. Circumferential burns around the abdomen are on this list due to the eschar formation after the burn, which reduces the size of the compartment in addition to the increased capillary leak. And then really, any pathology that increases edema in the abdominal compartment can lead to elevated pressures. This edema may come from volume overload and congestion, as we previously mentioned, as well as inflammatory processes, such as pancreatitis and sepsis. We've already gone over the manifestations of abdominal compartment syndrome based on the pathophysiology in the previous slide, so now we'll translate that into what is seen clinically. Patients may develop shortness of breath, abdominal pain, symptoms of heart failure, such as increased jugular venous distension, lower extremity edema, and acute kidney injury. The lower extremity edema does not mean the condition has progressed to heart failure. It may also come as a result of increased pressure in the femoral vein, leading to decreased venous flow and capillaries leaking into those tissues. It's important to remember that the clinical exam for abdominal compartment syndrome is very unreliable. For patients with a history concerning for abdominal compartment syndrome, such as the trauma victim receiving large volume resuscitation, it's important to measure the bladder pressures. Pressures greater than 25 to 30 millimeters of mercury are highly suggestive of compartment syndrome in the abdomen. This is in contrast to extremity compartment syndrome, which is a clinical diagnosis. All right, let's try a question. What supportive measures can be taken to decrease the risk of developing abdominal compartment syndrome? All right, there are a few things to consider that can help prevent the development of abdominal compartment syndrome. One is positioning of the patient. Having the patient supine without elevation of the head decreases the amount of pressure on the abdomen. This, of course, has to be balanced with the risk of ventilator-associated pneumonia or aspiration. Also, having adequate drainage. This includes nasogastric tubes, rectal tubes, paracentesis, and hematoma drainage. And finally, having adequate pain control and paralytics can also decrease the incidence due to the increased abdominal wall compliance. As with any critically ill patient, the airway, breathing, and circulation must be stabilized first. Treatment for abdominal compartment syndrome requires a decompressive laparotomy. The open wound is then managed with a vacuum-assisted suction device. Once the swelling has decreased, the abdomen may be closed. Further management is directed at treating the underlying cause. For example, in the case of an expanding hematoma, evacuation of the hematoma might be indicated. All right, let's try another question. A retrospective study is investigating mortality associated with abdominal compartment syndrome. The researcher is hoping to establish the leading cause of the mortality in these patients and then develop a protocol addressing the leading cause. Which of the following patients would most likely be excluded from this study? A 57-year-old male with caput medusae. B, a 45-year-old female alcoholic with pain in the epigastric area that radiates around the right side of the abdomen to the back. C, a 45-year-old male with unilateral 2+ pitting lower extremity edema edema and shortness of breath. D, a 52-year-old male who is the victim of an auto pedestrian accident who is severely hypotensive in the emergency department. Or E, a 75-year-old woman with vaginal bleeding for 3 years. One of the reasons abdominal compartment syndrome has such a high mortality rate is because it can lead to multi-system organ failure. It can also be caused by many pathologies, basically any that lead to increased inflammation and edema of the abdomen. Now, the 45-year-old with unilateral 2+ pitting edema and shortness of breath likely has a pulmonary embolism, which is unlikely to lead to abdominal compartment syndrome. So this makes C the correct answer. Caput medusae is dilatation and distension of the superficial epigastric veins associated with liver cirrhosis, which is a classic volume overload state because the blood that is filtering through the liver gets congested passing through the damaged liver, which causes the blood to back up into the veins that feed into it. This can lead to increased abdominal pressure and compartment syndrome. So A is wrong. Right upper quadrant abdominal pain that radiates to the back in an alcoholic is likely pancreatitis, which is a massive inflammatory state causing significant abdominal swelling and increased pressure with potential for compartment syndrome. So B is wrong. D is wrong because a patient with major trauma and hypotension is going to receive a massive amount of fluid, which places the patient at very high risk for abdominal compartment syndrome. The 75-year-old woman who has vaginal bleeding has endometrial cancer until proven otherwise. Where it has been going on for 3 years, it's likely that the cancer has grown to a considerable size. This places the patient at a double risk factor for compartment syndrome, the inflammation associated with the malignancy and an intra-abdominal mass, which makes E incorrect as well. So once again, the correct answer is C, the 45-year-old male with a likely pulmonary embolism. And that concludes this section.